Okay, shall I start? Okay, let's wait for more participants. Okay, assalamu alaikum. Hello everyone, good evening. I'm Sarah Alzahrni, fourth year RC student from Imam Abdurrahman bin Faisal University. I would like to thank you all for attending this session, and I would like to thank the Saudi Committee for Respiratory Care for giving me this great opportunity to share with you this presentation. Hopefully you find it useful, inshallah. Today I'm going to share with you an interesting topic that I do believe most of you never heard about it yet, which is prosthetic lung. Just to simplify the concept, the term prosthetic means artificial. So when we hear prosthetic lung, we might expect an artificial lung. But does this prosthetic or artificial lung maintain or preserve the same physiological function as the normal lung? So to understand the concept behind the prosthetic lung, let's get started. Just to make sure, is my voice clear? اكتبوا لي بالشات إذا ممكن.
Yes.
Okay. So these are the outlines I will be covering today throughout the presentation. First, what is prosthetic lung? Why do we use prosthetic lung? Definition and classification of esophageal lung diseases, clinical manifestations and medical interventions, treatment, complications, and lastly, the management. Prosthetic artificial lung. Prosthetic lung is an intrathoracic saline-filled tissue expander implanted into the hemithorax. So it's an intrathoracic expandable implant. But since it's filled with saline, that means there is no air, no gas exchange, no ventilation, or even perfusion. Then why do we use the prosthetic lung? Prosthetic lung is a surgical procedure that's used to manage patients with Post-Pneumoctomy Syndrome, which I will explain later in the presentation. But the prosthetic lung has a major role of repositioning the mediastinum, allowing the compressed airway to return to its normal position, reposition the heart intramedullary, relieving respiratory symptoms like progressive dyspnea, stridor, recurrent bronchial infection or abdominal pain, and decreases mortality rate, which all are complications of pneumonectomy. So, the saline-filled tissue expander in the cavity of the hemithorax is an effective means of decompressing the obstructed airways, repositioning mediastinal to the midline, thereby leading to a significant improvement in respiratory symptoms. It's mainly used to preserve the normal anatomical structure of the mediastinum. Actually, there are several investigations that could be done to determine the efficacy of prosthetic lung implantation. First, the chest radiography. Can you see the pointer? Okay. Yeah. Okay, this is the pre-implantation, and this picture is the post-implantation. Just X-ray film before implantation of the prosthetic lung demonstrates a shift of the trachea and the whole mediastinum. And we can clearly see the difference after repositioning and placement of the prosthetic lung in the post-implantation. The mediastinal shift clearly improved and the trachea returns to the normal midline position, which considered successful outcomes for sure. We can also determine the efficacy of the prosthetic lung implantation by the CT scan images. Picture A here, we can see that the mediastinal displacement and rotation of the with the tracheal compression, which is the white arrow, and a left main bronchus compression, which is represented by the black arrow. The post-operative CT scan here show a huge improvement after implanting the prosthetic lung, and we can easily recognize the difference after implanting the prosthetic lung. The narrowing is almost resolved with the left main bronchus and the trachea. One of the most cases that could be prone to post-pneumoctomy syndrome are patients with esophageal lung diseases that require pneumoctomy. But what is esophageal lung disease? Esophageal lung defined as a congenital malformation characterized by a patent congenital communication between a portion of the respiratory tract on one side and alimentary tract on the other side. It's a rare type of congenital malformations where a main stem bronchus is abnormally connected to the esophagus instead of the trachea. Esophageal lung is classified into 4 main groups based on embryology and anatomical features of the lung. The first group is when the bronchoesophageal fistula coexists with esophageal atresia, which means there is a connection between the esophagus and the trachea, which is tracheoesophageal fistula, in addition to the esophageal atresia, which is a blind-ended esophagus, rather than connecting to the stomach. Actually, this group is subdivided into 2 groups. 1A, if the whole lung is involved. 1B, if just a segment or loop is affected. As we can see here, the right lower lobe is the affected lobe. Moving to the second group, which refers to the presence of an undeveloped lung. Like what you can see here, it originates from the lower segments of the esophagus, and we can say that the whole lung origins from the esophagus in the second group. Moving to the third group, it's identified by a communication of an isolated lung or isolated segment of the lung with the esophagus or stomach. So the segment is separately connected to the stomach or the esophagus. The last group is when a portion of the normal bronchial system communicates with the esophagus. Here's the communication. The risk factor associated with esophageal lung diseases is that it occurs mostly in combination with other congenital anomalies involving esophageal atresia with tracheoesophageal fistula, as I explained before, and cardiac anomalies like patent ductus arteriosus and dextroversion. This picture simply represented the anomalies: esophageal atresia, which is a congenital birth defect that affects the alimentary tract. If you notice here, it causes esophagus to end in a blind-ended pouch, and instead of connecting normally to the stomach. The tracheoesophageal fistula is the abnormal connection of the esophagus with the trachea. Clinical manifestation and symptoms. The common presenting symptoms in esophageal lung are first, chronic cough, which is exacerbated during feeding, respiratory distress, recurrent episodes of pneumonia, hemoptysis, vomiting, and failure to thrive. The majority of these symptoms are present within the first few months of life. Medical investigations. Diagnostic procedures are either prenatal or postnatal diagnosis. I will start with the prenatal diagnosis. And also it's good to know that early diagnosis can lead to the repair of the anomalies at once with only one surgery. so the morbidity and mortality due to repeated surgery can thus be reduced. Here's the prenatal ultrasonography at 21 weeks gestational age. This is the right side, and this is the left side. The fetus is positioned head down. The ultrasonography is showing that the right lower lobe adjacent to the gastroesophageal junction and a tubular structure is found, which is the small arrow. Tubular structure is found which suspected the presence of esophageal lung. The MRI shows that the fetal pulmonary lesion, the large arrow, and here we can clearly identify the tubular structure that suspected the presence of the esophageal lung. Postnatal diagnosis, the investigation of a choice to demonstrate the congenital abnormality as esophagiogram with water-soluble contrast, which is a series of X-ray pictures of the esophagus taken after a patient drinks a clear liquid, the contrast. The contrast then will coat and outline the inner wall of the esophagus so that it can be seen on the X-ray pictures. Like in this picture, a diagnosis of right esophageal lung was confirmed. CT scan demonstrated right lung hypoplasia and it's totally collapsed. And lastly, with the chest X-ray, actually with the chest, we cannot confirm the esophageal lung from the chest X-ray only, since the parenchymal opacity observed in the chest radiographs suspected esophageal lung, but the diagnosis confirmed by esophagiogram. There are several complications related to esophageal lung, like rib and vertebral anomalies, multiple vertebral and skeletal deformities, esophageal and duodenal atresia, distal tracheoesophageal fistula, and duodenal stenosis. The vertebral anomalies and skeletal deformities mainly occur due to the cavity or the emptiness of the affected side of the hemithorax, but other complications are directly related to the pathophysiology of this condition, which involves the alimentary tract and the respiratory tract. The treatment approach used to repair esophageal lung is complete surgical resection, either total or segmental resection of the affected pulmonary segment or lung, which is pneumonectomy. But what makes the complications after the surgical treatment is that pneumonectomy results in excessively shift of the heart and mediastinum toward the side of the pneumonectomy, and the great vessels also rotate. After the total pneumonectomy, the loss of pulmonary volume causes a shift and rotation of the mediastinum toward the surgically treated site that can result in compression, stretching, and then malagia of the main contralateral bronchus against the vertebral column, which cause the syndrome that's known as Post-Pneumoctomy Syndrome. The Post-Pneumoctomy Syndrome causes a substantial functional impairment and can result in life-threatening bronchomalacia if inadequately treated. So, we can say that it can be managed well by implanting of prosthetic lung inside the pneumonectomy cavity, which will allow correct repositioning of the mediastinal structures and subsequent reduction of a pressure on the contralateral bronchus and achieve good results with lower morbidity and no mortality. As we can see here, tissue expanders are available with variable sizes and shapes. This is the self-sealing filling part in which the serum or saline is injected. And this is the part that preserves the normal anatomical structure, which is the intrathoracic expander. connected by this flexible plastic tube. And that's it. Thank you so much for your listening and time. If you have any question, you are more than welcome.